Hello and good evening, dear students. I am Dr. Ruchi Raj, your original guru for Prosthodontics, and I welcome you all to the live class sessions of Prostho beginning today, that is 29th of November, 5:30 p.m. onwards. For all our students that are seeing us live on YouTube, you can see the complete session and you can leave all your queries to me in the chat box. I'll be happy to attend those queries. So let us wait for a few seconds till all of our students join in. Meanwhile, all those who are live here, hello, just drop me a hi, hello, anything just to register your presence in the chat box. I can see all of your messages in our chat box over here on YouTube. So let us connect and let us start understanding Prosto. We'll begin within next 1 to 2 minutes till all of our students join, and then we'll start doing complete dentures from today onwards. So I can see that there are quite a few students that have joined in on the class. And can you give us a hello, good evening? Yes, good evening to all students. Good evening, everyone that have joined the class. Shilpa, Saurav, Pooja, Dr. Libra, Jyoti, Ranju Malika, Mosumi, Dr. Nimesh, Dr. Komal, Dr. Ninama, Gautami, Riya, Shivam. Good evening, all of you. Good evening, everyone. And it is very good to see all of you. Now, quickly let me know how many of you have attended my previous live class. Did you attend the previous live class, or this is your first time attending my live classes? Good evening, everyone. Very good evening to all of you. So, for all our students, for the first half of this session today, which will be live on YouTube, I'll check the queries that will be posted in the YouTube chat box. So, all our enrolled students, rather than putting the queries in Telegram, you can put it in the YouTube chat box. For the second half of the session, through the application, we can then either go through the chat of the application or go through Telegram. That is how it will go, right? So if you understood, just give me a thumbs up. All your queries in the YouTube chat box right now, right? So hello and welcome. Now I see a significant number of students have joined in for today's session, and it is very good that all of you are dedicatedly preparing for your exams, and I would like to help my very best for you to achieve that goal. So briefly to give you an introduction, I did my master's in prosthodontics from All India Institute of Medical Sciences, New Delhi. I was in the batch 2015 to 18. It's been almost how many years? 6 years, close to 6 years that I completed my post graduation. Approximately 10 years back, I was a student like you who was solving MCQs day and night just to get through my dream seat. And if I can be of any help to you, that would mean a lot to me. So, without wasting any time now, let us see how exactly actually Prostho is, right? So, up until now, I think we have discussed this several times, but for all the students that are here for the first time now, Prosto generally, you will find a bunch of conceptual questions, plus you will find some theoretical, or I should say fact-based questions that you have to just rectify, right? So first class for a lot of students, and I hope your class goes well with me. If you have any doubts, please feel free to always ask me. So conceptual part and some theoretical or a fact-based part, right? Generally through analysis of, I would say, last even 15 years papers also, what I've observed is complete dentures and RPD questions are mainly conceptuals. Occlusion questions are all conceptual questions. But FPD, implants, maxillofacial are more fact-based questions, which means you will be asked indication of a particular pontic. You've learned the indication, you are done and dusted with it. But with complete dentures, this time in exam, we saw a question pertaining to centric, which was asked, which required a thorough understanding of centric jaw relation. So that is how it goes. So in this live class, how is it different from our recordings or how is it different from any other sessions? We are here live, 1:1, where I can explain you through drawings or in other ways. This is a better tool of communication between us rather than a recorded lecture or something else. So my focus during these 25-30 hours of live class is to clear your concepts. Now, first things first, for my class, I would tell all of you, prefer to listen to me first and understand the thing rather than write down what I'm putting on screen. Because whatever I'm putting on the screen here is something that is already there in the recordings, something that is already there in the textbook, something which is already there in the notes. So you don't need to probably write down the same things again. It would be better if you would just try and understand me over here. That would be better because that is how you develop those concepts and those doubts that keep bugging you again and again, which we have discussed several times in our Telegram group. That is something that we would try and clear out over here. Now, okay, so a lot of students are saying they have attended my GT sessions. I hope they were good for you. Now, without wasting any time now, let us begin first with what I call is the most basic of prostho, right? Retention, stability, and support. Now, students, apart from this, just let me know, is my speed fine or am I going too fast for you? Now, quite a few students are directing queries pertaining to joining DBMCI. I'll advise you, please direct those queries with the appropriate person. I link you up with them and they would be better taking up those questions for you. How to join DBMCI, right? Now, is the speed fine for all of you? How we are discussing, is it fast, slow? Are you facing any issues? It's fine. Okay. Right. So what I would say is the dictionary of prosto are these three terminologies: retention, stability, and support. More important in RPD than in complete dentures, but still I would begin my class with these three terminologies only, which is retention, stability, support. Reason is that now further in class, I will start talking in this way that okay, this particular component is responsible for stability, or this component is responsible for support. At that point, you should be able to click and understand what that terminology was. You won't be able to remember this in one go. So I'll advise you revise and revise this portion again and again till the time it comes naturally to you. Now, before we start retention, stability, and support, as a general understanding, I'll teach you something. In our oral cavity, mainly two kinds of actions happen. If everything in the mouth, if I want to classify, I'll classify in two kinds of actions: functions and parafunctions. Functions are what? Swallowing, speech, or mastication, lot of different things, right? These are your functional activities. Parafunction would be your clenching, bruxism, or grinding. All of these are parafunctional. Every activity of the mouth can be classified under these two actions, functions and parafunctions. And all of these will generate forces, right? All of these actions generate forces. These forces in turn lead to stresses on the different stomatognathtic structure, mainly your teeth. Now, the purpose actually is that the stress which is acting on the tooth is ultimately transferred to its attachment apparatus and ultimately transferred to the bone where the stress gets absorbed and then remodeling also occurs of the bone. That is the basic gross layman term cycle of it. What happens is these stresses, now again, if I want to classify them, mainly there are two directions of it. Either they can be along the long axis of tooth, so along long axis of the tooth, so vertical or in the vertical direction, or they can be non-linear, so they could be horizontal or oblique. So could be like this, could be like this, could be like this, could be like this. Fine. So this is how the stresses generally are. They are either along the long axis of the tooth or they can be going out in different directions like this. Fine. Now, what happens is that the Stresses along the long axis of the tooth, they are very well tolerated by the attachment apparatus. But these horizontal stresses, they are not very well tolerated by the attachment apparatus. So all of these properties we'll discuss in terms of these stresses only. Now we have to understand what these properties are. First now, again before starting these three properties are properties of the prosthesis. Matlab, a complete denture is retentive. A complete denture is stable. A complete denture has good support. It is a property of prosthesis. It is not a property of the mouth. It is not a property of the hands of the clinician. It is not a property of hard palate or buccal shelf area. It is a property of the prosthesis. A prosthesis is retentive or non-retentive, stable or unstable, or has good support or no support. So first understand that these three properties are properties of prosthesis. Now, how did they come to the prosthesis? We as clinicians give them to the prosthesis. How do we give them to the prosthesis? For example, when I make a very good impression that extends to all of the different areas of the mouth, I am rendering very good support to the prosthesis and very good retention also. When I select very good occlusal scheme or the correct occlusal scheme, I'm rendering stability to my prosthesis. So a clinician through different steps of prosthesis construction is going to render these properties to the prosthesis. I hope you are following what I'm saying. Are you able to follow what I'm saying? Give me a thumbs up, give me yes, no, anything in the chat box. So that is retention, stability, support, or anything about these properties, right? And those areas of the mouth which will help execute them. For example, hard palate is the supporting area. So that area which fulfills the property is that particular area of the mouth, like supporting area or stabilizing structure or retentive areas of the mouth. Now, do you understand these three things? Properties are of the prosthesis. Who gives them? The operator gives them to the prosthesis. How do we give them? By different steps of prosthesis construction, by proper impression making, by proper jaw relation, by proper occlusal scheme selection. And when these areas of the mouth contribute to these properties, they are labeled by those names like supporting structures, retentive structures, and stabilizing structures, right? So I think this portion would be clear now. Now let us dive deep into what retention is, what stability is, and what support is. It took me, I think, quite a lot of years to understand these actually and then bring them into my practice. Any prosthesis construction is a game of these three things only. You have to decide, how do I give retention? How do I make my prosthesis stable? And where do I gain my support from? If you're able to decide these three and efficiently deliver them, you will never have any problem with any prosthesis in life. Take it from me in that way. That is how these three work. We have to think in that fashion. Now, begin with retention. That quality inherent in the prosthesis. We discussed it right now. It is inherent in the prosthesis, acting to resist the force of dislodgement along the path of placement. So, for example, mandibular denture is like this. So, anything that lifts the mandibular denture up, or maxillary denture, anything that makes the maxillary denture fall down, these are called as dislodging forces. And anything that acts against these dislodging forces is retention. So, by this, we understand this works in the vertical component, this component of force. The vertical component along the long axis, retention works along this, along the vertical component of force. That is how it works. So retention is anything that will try to resist the dislodgement of the prosthesis, generally against the vertical component of force. So anything that prevents falling of maxillary denture down, or anything that prevents lifting of mandibular denture up, that property is retention, right? Coming to stability. Let us take up support first and then we go to stability. Now, what is support? Whatever forces are acting onto the prosthesis, so the foundation area on which the dental prosthesis would rest, or whatever forces are acting towards these prostheses, any resistance to these forces is called as support. For example, if I have a crown like this, resistance to these occlusal forces means the ability to take up these occlusal forces. When are they generated? Mainly mastication, swallowing, speech, all of these activities will generate these vertical forces. So any resistance to these vertical forces to absorb and then let it dissipate downwards, that property is called as support. So again, something pertaining to vertical component of forces, that will be support. So that is retention and support. Now, you all must be thinking support's main role is in mastication. No, it is not. It is mainly during swallowing, because every time you swallow, your teeth will touch, and every time they come in contact, what happens? Some amount of occlusal force is generated, which will then be actually transported and dissipated through the underlying structures. So anything that helps resist these occlusal forces and then dissipate them through the underlying structures, that property is support. So resistance to forces directed towards the basal tissue or underlying structure, that is called as support. I hope retention and support, everyone, is it clear? Can you give me a thumbs up? Yes, yes, receiving quite a few thumbs up. So retention and support, I think, is clear for all of you. What do you want to say? Fine. So I think that is done. Now, the particular chair that I'm sitting on right now, or the chair that you are sitting on right now, a chair has four legs. For example, if I chop off 1/4 inch of one of the leg, the chair will start to rock like this, right? The chair starts rocking. What do we say? The chair is not stable, unstable here. Anything that is rocking, anything that moves like this, what do we say? This particular thing is not stable. That is how we use the terminology in layman terms also, right? So whenever we have a denture and there are horizontal forces acting like these that try to rock the denture, that try to make the denture move like this, these are all destabilizing forces. And that property of the prosthesis that counteracts these destabilizing forces is called stability. So, stability is that quality of maintaining a constant position in presence of forces that threaten to disturb it, or rather, I would say, resistance of displacement by functional horizontal or rotational stresses. So anything that causes horizontal forces like these, anything that will lead to any horizontal forces which has a tendency to rock the denture, anything that will rock the denture like this. And what will help counteract those rocking movements, that is called as stability. Now there are various things that contribute to stability, but the number one factor that will contribute to stability is occlusion. Occlusion is the number one factor that contributes to stability. So with this we will conclude these three terminologies, and I start with maxillary anatomical landmarks. But before that, can you all give me a yes, no, thumbs up, any query that you have? Students, we have about 117 students live right now. So can you just give me a thumbs up? Yes, did you all understand about retention, stability, support? Yes. So quite a few yeses that say that I think you have understood. Yes. So everyone is saying yes, that is good to go. Now remember it, there's a small video of me, about a 10-15 minute video labeled Basics of Prosthodontics in your recorded videos. If you want, you can go back to it and you can check it again. Try and revise it every day, especially when we do removable partial dentures, so you are able to understand it better. So that is about retention, stability, support. Now let us begin with maxillary anatomical landmarks, right? Now for life class, I won't write everything down that I used to write in recordings because you already have those notes. We'll try to discuss the concept better over here so that on one level, we're able to clear off any doubts. You already have those notes with you. So I won't put everything down into paper from today onwards, right? So first and foremost, maxillary landmarks. Why is it important from exam point of view? Live classes, I'll discuss purely from exam point of view, completely from exam point of view. Even for your final university exams, these are helpful. But my focus primarily is NEET and INI CET now. So maxillary anatomical landmarks, what kind of questions, or from landmarks, what kind of questions can be asked? Simple, straightforward, fact-based questions of muscle attachments, movements of influence of different muscles. All of these are asked, or probably some anatomy or physiology-based questions out of these are asked, right? So let us begin with landmarks. Now, all of you are aware, landmarks are generally divided into three categories. Maxillary landmarks, they are divided into three categories. They are supporting or stress bearing structures because they will bear up the stress. Then you have relieving structures and you have limiting structures. Now, very briefly, those areas of the mouth that help absorb the forces of occlusion and then dissipate through the underlying structures. These are supporting structures of the mouth. They render support to the prosthesis. Those areas of the mouth which are incapable to take any stress, which are very delicate, not capable to take up any forces, are to be relieved. They are relieving structures. And limiting structures are what? They decide the outer boundary of a denture. That means denture should not cross beyond this particular area. Let us begin first with the limiting structures now. So limiting structures in maxilla. Simultaneously, I'll keep an eye on your chat box also so that we can have an idea. If you're posting any queries, I'll take up those queries also. Till now, I think no query has been posted yet. Fine. So let us begin with now the limiting structures. Limiting structures, first of all, if you can see here, is labial frenum. Now the word frenum here means a fold of mucous membrane. When there is a fold of mucous membrane, it is called as frenum. So as you can see here, this is labial frenum. Now the important 2-3 points pertaining to labial frenum is it has no muscle attachment. It has no muscle attachment. What is the significance of muscle attachment? When there are muscles attached to something, these muscles, whenever they move during function, that structure will also move. So you need to create room for that particular structure in the shape of the border of denture. So the border of the denture should then move in shape according to that particular muscular movement. But if a particular structure has no muscle attachment, you can just give a very small normal relief to it, like an eye-shaped relief like this, and that should be enough for that particular structure. So it is a single fold generally present in the midline, divides the labial vestibule in two halves, has no muscle attachment. Now come from there, the second structure is labial vestibule. So the labial frenum here divides the labial vestibule into two halves like this. It extends from one labial frenum to one buccal frenum. So this area is called as your labial vestibule. Now labial vestibule, it extends on both sides of the frenum and it contains muscle fibers. So we will mold it with border molding. As in when we do border molding, we'll mold this particular area. Now, after that, the third limiting structure is buccal frenum. So as you can see here, this particular fold of mucous membrane that you can see is a buccal frenum. Now, buccal frenum is slightly different. Either it can be one fold or it can be multiple folds also. Plus, buccal frenum has muscle attachments. So, what are the muscle attachments? It is generally asked now. Now, for a maxillary buccal frenum, if this is the front part of the mouth, say this is the oral cavity, this is the posterior part. Okay, so orbicularis oris, right? Anteriorly, orbicularis oris, it will pull the frenum forwards. Buccinator, it will pull the frenum backwards. And caninus or levator anguli oris. Levator means because it elevates the frenum. So levator anguli oris will elevate the frenum. So three muscle attachments on the buccal frenum. So the clinical point out of it is that for a buccal frenum, we give a wide cricentric relief. Cricentric means like a half moon. We have to give a wide cricentric relief for our buccal frenum because every time orbicularis oris will pull it forward or the buccinator will pull it backward or the caninus will try to elevate that particular frenum, the structure will move. Structure will move means it will influence the periphery of the denture. Now, that is why the denture's shape should have some relief for it. I hope you understand this particular point. So that is about your buccal frenum. Yes. So now we have a question that labial vestibule, does it have muscle fibers? So there are muscular structures, modulus that is surrounding it, and the muscle fibers run horizontally in this area. So that is how whenever the muscle contracts, it will affect the height as well as the width of labial vestibule. So they are definitely present in that region. I hope that solves your doubt. Now coming to buccal vestibule. Now this here is very important. The fourth part, which is buccal vestibule. Right? So buccal vestibule extends from the buccal frenum and goes till the end of tuberosity in this region. From this section, several questions have been asked. Why? Because in this region, there is influence of a lot of structures. Now, first and foremost, it extends from the cheek over here and goes up till the crest of the ridge. Posteriorly, it is present near the hamular notch here. Right? What questions come here? The questions that come from this region are pertaining to thickness of flange of denture. Now, for all of you, I'll ask you to do one exercise here. Open up your mouth, take your index finger and put it in the buccal vestibule that is above your first molar. Just do it simultaneously with me. So I think, are you all doing it? Just put your index finger in the sulcus that is above your first molar. Now try opening the mouth very gently and closing the mouth. And what do you feel? Do you feel reduction in the width of the sulcus in that region in buccal vestibule? Or do you feel that the space has increased? Do you feel a reduction? When you put your finger in the buccal vestibule and you open your mouth, you will feel a reduction in the width of the buccal vestibule. Do you all agree or do you feel that? Yes, no, thumbs up, anything would be fine. Yes. So I think Kirtik is saying that you feel a reduction in the buccal vestibule. Yes. You see a reduction. Yes. So what is happening is when you open the mouth, the coronoid process of the mandible comes anteriorly. The coronoid process comes anteriorly, and because of that, the distobuccal region, specifically the distobuccal region, distobuccal portion here, it narrows down, right? So, when we are doing border molding of the buccal vestibule, if we have not done molding in a manner where we ask our patient to open the mouth and close the mouth and take the mandible to side, you have not molded the buccal vestibule according to your coronoid processes movement with the mandibular opening. So, what happens is the thickness of the buccal flange in such kind of border molding will be thicker. So the question that comes in your exam, clinical question that comes is, patient comes to the OPD with the complaint that as soon as I open my mouth wider, the denture falls down. So what is the reason for it? So let us take up that clinical question because that is a source of doubt for a lot of students. If the patient comes with a clinical complaint that denture falls down with wide mouth opening. That is this situation that we discussed. If you have not done this border molding of the buccal vestibule, where you have not asked the patient to open and close the mouth and take the mandible to side, the resultant flange will be very thick. As soon as you open the mandible, the flange will interrupt with the coronoid process and the denture will fall down. So that happens. So if the patient comes with a complaint, denture falls down upon wide mouth opening, the reason is thick distobuccal maxillary denture flange. Please write this down, all of you. This has been asked several times in your exam. Denture falls down with wide mouth opening. The reason is thick distobuccal maxillary dentures flange. This is because of coronoid process. This is because of interference with coronoid process, right? So this is due to interference with coronoid process. Now this is one version of the question. Second version of the question is what? Second version of the question is patient complains of denture falling down upon smiling, right? So when the patient is smiling, not opening the mouth wide and the denture is falling down, upon smiling, all of this region comes into play. So when the patient smiles, what comes in this region? Can you all tell me what structure or muscles are influenced in this region of the mouth? When you smile, which part of your sulcus is getting stretched? Which structure comes into play? Can you just quickly type it in the chat box for me? So I'm waiting for you. Just quickly type in the chat box for me over here. Yes, excellent. So the structure that comes into play is buccal frenum. So when the buccal frenum has not been adequately relieved, when the buccal frenum is not adequately relieved, the chances are that denture will fall down upon smiling. So two clinical situations that come as questions in exam. So if a buccal frenum is like this wide, you need a wide three-centric relief for it. But for a labial frenum, you just need one eye-shaped relief because it does not move with muscles, right? So I think you have understood this part. So this is how questions come as troubleshooting questions also from maxillary anatomical landmarks. Now let us go back to our landmarks. Is this portion fine for all of you? Can you give me an okay or a thumbs up? Now, after your buccal vestibule, let us discuss about, yes, so received some yeses from you. Let us move ahead. Let us discuss about pterygomaxillary notch or hamular notch, right? So hamular notch will be located in this region behind the tuberosity and before the hamulus. That is where the hamular notch is located. This is the end point of a denture. You can't go beyond this. When you extend beyond this, you are walking on the hamulus of the pterygoid plate. And because the hamulus is a sharp beak-like projection, it is a sharp beak-like projection like this. If you impinge on it, then you are actually causing pain to the patient. So an overextension in the hamular notch region will lead to pain. So let us quickly draw it out. Maxillary tuberosity. This is your hamular notch or the area of pterygomaxillary seal. Now behind this here, you will have your hamulus of pterygoid plate. So by chance, if you overextend onto this hamulus is like a beak-like projection. So when you overextend onto it, patient will complain of sharp pain, right? So how do I come to know that I have correctly ended in hamular notch only and not overextended? There is an instrument which is called as T burnisher. I'm sure all of you would have seen. Have you seen a T burnisher, students? You all would have made dentures. So have you seen a burnisher like this, a T burnisher? It has a ball end like this and then a flat end like this. Have you all seen this T burnisher? Tell me yes, no. Have you seen a T burnisher? Right? So this particular T burnisher is gently, it is like a V, right? It is like a V. So it is gently walked across the alveolar ridge. And then as soon as it falls into a depression, that depression is your hamular notch. That is where you end your denture. So again, you connect the dots on both sides, which means that you start from your labial vestibule, labial frenum, vestibule, buccal frenum, vestibule, hamular notch. Same, you go on the other side and you come here and then you join with the post-palatal seal. That is the entire limiting structure of your maxillary denture. So any doubts in limiting structures, anyone? Any doubts, any queries, any questions? I think so. Might not have any doubts, but still better to ask. Now at the posterior border, yes, there's one more thing now at this posterior border that we see, which is called as fovea palatini. Fovea means an opening, right? So two small dots like these may or may not be seen in patients. May be seen, may not be seen. These are coalescence of opening of minor salivary glands. Minor salivary glands that will give out secretions. So the clinical point here is that if the posterior part of the mouth contains this fovea palatini and there is a very thick ropey saliva, chances are that it may dislodge the denture. So you have to appropriately develop your seal at the posterior border. Now, a question that actually confuses a student regarding position of fovea palatini. Our say on it is that its position is not fixed as per recent literature. Its position is not fixed in the mouth as per recent literature. Not always on hard palate, not always on soft palate. So its position is not fixed, right? So do you agree with that? Now I'm uh, what do you say, answering all of the doubts that are very frequently discussed in our Telegram group. So these are all the questions that come up again and again as snapshots. We are always solving those questions. So that is fovea palatini. Now again, since we are at the posterior border, let us discuss something about the posterior border and soft palate also. Now the junction of hard and soft palate is where your posterior palatal seal area arises. Posterior palatal seal area comprises of resilient tissue. Resilient means something on which you can put pressure and it can absorb that pressure within physiological limits. That is called as being resilient. So there is a band of resilient tissue at this posterior border of the denture. So pressure within physiological limits is applied at this posterior border to develop a very good posterior palatal seal area. Now, the junction of hard and soft palate, that junction and the angle of that junction will determine how good a PPS you are able to establish. So when the junction of hard and soft palate is approximately at 10 degrees, you get a wide area like this, right? To develop very good PPS. So this is the best case scenario for developing a very good posterior palatal seal area. Now, when you see a drop, an angle like this, which is 45 degree, then it is class 2. And when you see a sudden fall, it will look like a curtain, then it is class 3. Now, clinically what happens is, when I see my soft palate completely horizontally, that is almost class 1 because there's no instrument with which you can measure the exact angle of it. But when I see a sudden fall of soft palate, that is class 3. One arrives at the diagnosis of class 2 with experience where you're able to judge that it is class 1 or class 2. So this is just an estimation that we do clinically only. Now, this is about your junction of hard and soft palate. Let me see if I've missed anything because it's a big document here, right? So now let us discuss the supporting structures. We have discussed fovea also. We have discussed soft palate also. Let us begin with supporting structures of maxilla. Students, right? Okay, so now we have a query. Please explain PPS and vibrating line. PPS I just discussed. I can discuss vibrating line with you. So we have two kinds of vibrating line. Anterior vibrating line and posterior vibrating line. Yes, I'm discussing vibrating lines. So first and foremost, remember vibrating line is an imaginary concept. It is made by us to understand the hard and soft palate better. Understood? Vibrating lines are imaginary lines. They are not there actually in the mouth. They are imaginary lines. They are to better understand the area of posterior palatal seal area. Now, to understand them, you need to understand how the posterior part of the mouth is. Hard palate is a firm structure that is the tissue or the hard palate is firmly attached to the bone. At the posterior border of the hard palate, you will start seeing some movement. And then as you progress in soft palate, you will see marked movement. So the junction between no movement and slight movement is anterior vibrating line. And the junction between less movement and marked movement is posterior vibrating line. Firstly, have you understood this or not? No movement and slight movement is anterior vibrating lines junction, and limited movement and marked movement junction is posterior vibrating line. Have you understood this much? Yes. Yes, Nami, yes, I changed my username on Telegram. You posted it out. I changed my username on it because Telegram, we are facing a lot of spamming, which is why I say that always post queries in the group only because we face a lot of spamming on Telegram. So that is why we keep on changing things over there. Now, so this much I think you have understood. How do I identify anterior vibrating line? When my patient will do small bursts of short, vigorous bursts of right? So it is something like that. When you do such short, vigorous bursts, you are identifying anterior vibrating line. And when we just ask the patient to say normally, when you say we are identifying posterior vibrating line. So short, vigorous bursts, anterior vibrating line. Normally, when the patient will say is posterior vibrating line. So that is about vibrating line. Now let us come to supporting structures. Supporting structures of maxilla. Now, like I discussed before, support is that property which will take up the occlusal forces and dissipate to the underlying area. Always remember, due to different editions of Boucher, this confusion is there. But according to the most recent edition, stress bearing area of maxilla is hard palate, not residual alveolar ridge. The main stress bearing area is hard palate. Remember that. I don't want any confusion over it. If you find any confusion, that is because of older editions of Bouchers. In ninth edition, it has been stated residual alveolar ridge. That is why there is a confusion. But the concept has evolved over years. So that is why currently it is followed that this portion of the hard palate is responsible for the stress bearing. After that, you have your residual alveolar ridge. Now, the reason for is very simple. It has cortical bone, it has firm resilient mucosa, it has wider surface area, forces are at 90-degree angle to it. That is why it is the stress bearing area. Secondarily, then even residual ridge, rugae, all of this also contribute to your support. And after support, what we have are our relieving structures. So let me just open up our relieving structures. Yes, over here. So relief areas are those areas that cannot absolutely take any forces. So the first relieving structure that we have is incisive papilla. As you can see here, generally present behind the maxillary central incisors, it is where nasopalatine nerves and vessels would go to and fro between the nasal and oral cavity. So when you compress on it, you are compressing the blood as well as nerve supply. It can lead to paresthesia and pain in this region, right? Second is mid-palatine raphe. So mid-palatine raphe runs like a thin line. It is actually at the suture or the junction of both of the palatal plates. And this mid-palatine raphe is a weak point at which the denture can even rock also sometimes. So that is also relieved. And lastly, you have your fovea because of the saliva, thick ropey saliva sometimes present underneath. You have to relieve these structures. So these are your relieving structures. Students, able to follow? Likewise, Ayush, Cupid's bow is the area between the two vibrating lines. Generally, anterior vibrating line runs like this. Posterior vibrating line runs like this. Area between them is your posterior palatal seal area, and this particular shape is your Cupid bow shape. So I think with this we will conclude maxillary anatomical landmarks. I hope all of you have understood this much. Students, post-dam area, posterior palatal seal area, the same only. We will take it up in details when we do impressions also. Chabi, can you be specific which classification of residual alveolar ridge are you talking about? Are you talking of Atwood's classification? If you're talking about Atwood, I'll discuss it under residual ridge resorption, not right now in landmarks. Okay, apart from that, students, any doubts? Any doubts, anyone? No doubts, right? So we will conclude this particular portion of the class here. You can take a small 5-7 minute break. And so now we will discuss how to record PPS in the impressions portion. This is just about landmarks. When we go to the next chapter of impressions, we can discuss over there. So like I was saying, you all can take a break. I'll stop the streaming part over here. Then we will transfer to the next section of the class that will continue up till 9:30. As always, for all those who are watching us on YouTube, if you still have any doubt, this video will always be going to be there on the YouTube channel. Post your doubt underneath as in the chat box. Whenever I'll come back to you, I'll try to solve up your doubts. We are always available on Telegram, Facebook, and other mediums also, where you can contact us and be in touch with us, and we will be happy to solve those doubts. So just take up a 5-7 minute break. When we rejoin through the new link, I'll just drop in a message in our Telegram group and we can restart the session, right? So I'm just dropping the streaming over here for all the students who joined for this YouTube session, the free part of the live session. I hope this class was helpful to you and you gained some